chapel. So I don't think that I'm I actually think that my viewpoint represents mainstream public health. Because mainstream public health as of February 2020, not mainstream health today. So I'm going to try to make the case for the alternate strategy I'll describe in some of you will hear of. But I want to start by making the scientific case, and then we'll turn to policy. Because it's very, very simple. There's actually only two reasons, two basic facts we need to know to understand why this policy is not. The first is the death rate from this disease. The first is the death rate from this disease. The second most important fact about this disease from a clinical point of view is the risk stratification by age. Older people are 1,000-fold more likely to die from this disease if infected than children. Normally, in public health and epidemiology, you look for variables that allow us to stratify risk. Why? Because then we can focus our attention on people that are the most harmed, most at risk. Finding personalized medicine, you find a variable, a risk stratified by free flow. You have found a variable you can use. Cancer treatments we find on things less than 1,000-fold difference is an enormous risk stratification. Just to give you some sense about how large this is. If I get infected, I'm 53 years old, if I get infected, roughly speaking, my mortality rate without the vaccine is about 0.2%. So 99.8% survival if I get infected without the vaccine. Okay, you want to calculate your survival. You're not 53. How do you do that? It's actually really simple. For every 7 years of age up, you double the risk. For every 7 years of age down, you half the risk. Every 7 years of age up, you double the risk. Every 7 years of age down, you half the risk. So, for instance, someone who's 46, their risk is 0.1%, 99.9%, 39.05%. So, 99.95% survival. Those young people in the audience do better at doing that on the fly than I am, and just keep going down every 7 years. The survival rate for a child is better than 99.999%. Young people face vanishing low risk from mortality from this disease. On the other hand, if we move up the other direction, 53 to 60, we're off 0.4%, 99.6% survival. 67, 0.8, 99.2, 74. Now we're starting to get into numbers that you really should worry about. 1.6%, and then 81, 3.2%, it doubles. And so for the elderly, this disease poses an absolutely catastrophic risk, much higher than the typical flu, much higher than the flu. So you have essentially groups of people that face very, very different risk profiles. Let me just tell you briefly how I know these numbers. So there was in the early days of the epidemic, if you remember that, there was the World Health Organization put out a number suggesting what the rate of death from this disease actually was. The number they said is 3%. 3%. That number was derived from a very simple calculation. They looked at all the people that had been diagnosed with the disease in the denominator, and then the numerator put the number of people that had died from the disease. To date, up to that date, it was February, March 2020. That was 3%. 3% of the people that were found to have the disease died. Now the thing is, how do people get identified with this disease back then? They showed up in the hospital, really sick. I've been working a decade before on H1N1 flu. And this is not the kind of study that I did back then, but there are a bonus set of studies that documented that for H1N1s, there were 100 times more infections than cases. 100 times more infections than cases. Cases were identified by people showing up in the hospitals. Infections were identified by something called seroprevalence. Seroprevalence in this context means they take a little bit of blood from you, and then check to see if they have antibodies. But when you have an antibody that's specific to the virus, that means that's evidence that you were infected, even if you never felt really sick, even if you never showed up at hospital. Grade 1 and 1, the early estimates of mortality of the case fatality rate was something on the order of 3, 4, 5%. And by the time the seroprevalence studies were done, it was 0.01, 0.02%, 99.99% survival. Very different picture. In the early days of the epidemic, I had a hypothesis that we see something similar in the context of a respiratory virus. And so I run a seroprevalence study in Santa Clara County and in LA County, which found exactly that. But it wasn't 100-fold, it was like 40-fold, 50-fold. And the mortality rate was 0.2%, just the representative. Now there's over 100 of these studies, and all reach the same conclusion. Okay, that's it. That's the science. Fact one of the science. This is not as if it's particularly controversial. Okay, let me give you fact two of the science. Again, this is something that's not particularly controversial. The policy that we follow, the lockdown-focused policy that we follow, has as its goal the separation of human beings from one another. The logic is so simple that it's almost impossible to argue against this as being effective. But the idea is that if we are not near one another, if we live our lives apart from one another, well, then we have no risk of spreading the disease to one another. The disease spreads by little viral particles going from one person who's sick to someone who's not sick, colonizing the nose generally, and then spreading. And usually it's by aerosol. So like as you breathe it out, it comes in the air and you breathe it. That's how the disease spreads. Most of the time. Of course, we didn't know exactly how to spread it. But what we did know led us to think that if we keep people apart, the disease will spread less. That's not the science I think I want to emphasize. The science I want to emphasize is that the act of keeping people apart from one another itself imposes enormous harms on people. The act of keeping people apart from one another imposes enormous harms on people. And I don't think there's a single person in this room or even in this audience listening that doesn't believe that. Because we felt it in our lives at every moment of the lockdown. Even as the lockdowns were lifted, we still kept this idea that we should be part of this. So we closed schools, we asked university students to go home, we told people to stay home and work instead of coming in here. We closed bars, we closed restaurants, we ended international travel, we sharply reduced international travel. We adopted a policy to create fear in the population of other human beings. That's the policy we got. And while some elements of that policy get rescinded, the element of causing people to fear one another, to fear the presence of one another, is still a hallmark of public policy. So what are the consequences? If you think about this intervention, it cannot possibly be. So let me give you one example. So newborn babies born to a COVID-infected mother. Keep them apart. Should newborns be with mothers? They're not in the United States, but there are some places where mothers, Australia, mothers and children, newborn babies were separated. How about older people dying in nursing homes? Right? The last visit. Do you let them see them? Right? Well, in many places, including in the United States, we told people to die at home, apart from visiting people at hospitals. Actually, it turns out in medicine, these kinds of visits are not an option. If you do them, you actually promote out people's psychological well-being depends on seeing loved ones, especially when they're in high schools. We stop those visits. We ask young people to not interact with other young people for fear of infecting older people. And so we said to young people, don't don't go to school. If you're a kindergartner, learn to be on Zoom. We ask people if this is a policy, an actual policy in Australia. If you're an Australian, you live outside Australia. If your father is well, you can't go. It's going to take you. It's going to make you have to be in quarantine for 2 to 3 weeks, and it's very likely you won't be able to work at all, even though you're Australian citizen. We stop people from crossing borders in ways that we have not seen since World War II. And we, for the last 30 years, we've had a policy in globalization, creating interconnections between nations, trade relations, but also human interaction between people in different countries. We valorized travel, and all of that ended last year. So what are the consequences? And again, this is I think science is just basically normal dispute. Let me start at home. And let me just, rather than focus on economic aspects of it, because I think the economic aspects are all important, really don't hit home as hard as some of the health aspects of it. So let me just talk about the psychological ones. Last year, in the CDC, they had a study in July last year, where they asked people, large sample of people across the country, a very simple question. Did you seriously consider suicide? There's only, when that question is asked to young adults, the answer is about 4% of people are serious. Last year, in July of 2020, 1 in 4 young adults answered yes to that. 1 in 4 young adults. Older people, 1 in 6. An enormous increase in suicidal ideation. But that's just the tip of the iceberg. Right? The psychological harm from this is likely, if anyone has spent the time last year under lockdown understands this. It is a difficult thing to stay apart from people. And it is automatically going to cause distress. We are not meant to be alone. I read that in a famous book. People talk about shadows. We're not built to be alone. And that is absolutely true because the psychological influence. It's not normal to be alone. It's not normal to ask people as a public health official to be part of it. And yet that's what we do. The psychological consequences are not things that just go away. In fact, we're starting to see already some of the consequences. Suicide rates have been down last year. But the psychological harm is continuing. And will continue. Something we're going to need to press over and over long. Well, what about physical? Well, we told people that COVID is so important that you need to stay home. There are people with heart attacks that stay home. The emergency departments were half empty last year because people were more scared of COVID than they were of a heart attack. People stay home with cancer, skip cancer treatments. Women this year are being diagnosed with late-stage breast cancer that should have been picked up last year at an earlier stage. They're going to die with breast cancer just to avoid the risk of COVID getting screening or a regular vaccine. Colon cancer is the same story. If you look at human disease, there are many, many threats to human disease, to human health, that are more important. It sounds like for me to say it, but it's actually true. Cancer kills more people. Heart disease kills more people. Even in developed countries where we thought we had conquered infectious disease, COVID, even as it's killed 700,000 people in the United States, is still not the number one killer. And we decided that we would ignore all these other priorities of human disease in order to address COVID. The long tail of these lockdowns will continue for a very long time. There's still a huge overload of cases with cancer that happen in diagnosed, happen in screening. The rate at which young infants are given the normal vaccine, the MMR-GBT, has dropped, a sharp increase in the number of unvaccinated infants. For vaccines that protect against diseases that actually are quite harmful to children. Okay, so that's the development. That story is true to some degree or another. Every single country is following systems that are likely to be overwhelmed by this backlog of disease that we caused for fear. What about developing countries? In developing countries, the harm is even worse. So this system that we've developed at local station, 100,000 people, 100 million people were thrown into poverty in the last year. 100 million people. We have, over the last 30 years, pulled a million people out of poverty because the globalized trade systems we created wealth, although it was very unequally distributed. At the bottom end, we pulled a million people out of poverty. A billion is the estimate. But that came at, it didn't come for free. What it came at, it required poor countries to reorganize their economies so they could fit into this global system of economic trade. Local economies that were relatively self-sufficient, essentially by connecting them to the global economy, produced unimaginable wealth in the last 30 years. Some of it distributed poor. Some of it distributed very poor people, lifting them out of poverty. Overnight, we closed that way, we shut it down, we said lockdowns, we reneged on our promises. And 100 million people were thrown into poverty. $3 a day, more or less. 80 million people were thrown into dire food insecurity. Food insecurity means if you go to that hunger. And hundreds of thousands of children died as a consequence of hunger. There are programs for vaccinating large numbers of infants worldwide that were ended. Malaria eradication programs, programs to address malaria, and we stopped tuberculosis treatment. The fact that hundreds of thousands of people died of tuberculosis this year should have been saved. HIV treatment worldwide. The harm from the lockdowns in poor countries is almost impossible to imagine. And without, the only question in my mind is how large those harms are, whether 1, 2, or 3 orders of magnitude greater than the number of lives we might have saved. Okay, so those are the two facts. Those are the two scientific facts. First, that there's this age gradient in mortality from COVID, and second, that there's catastrophic harm to people. I'm an economist. You have to think always as an economist in terms of trade-offs. There is no free lunch, is a different. And that is certainly true. We are in the midst of a terrible pandemic, and it is a real pandemic with a virus that it poses a risk to an important part of our population. And yet, the way we address it should not also itself cause other parts of the population. So let's put those two facts together. The Great Barrington Declaration was a statement that I signed with, professor at Oxford, Sunetra Gupta, who's professor of theoretical economics, and Professor Martin Kulldorff at Harvard University. He's one of the people that designed the system by which that public health agencies around the world track vaccines. He identified the Legionnaires outbreak in 2015 before anything else, and the rest was brilliant science. And the idea is very simple. For older people, we have to work very hard to protect them because the risk of case infection is really high. So the first idea of Great Barrington Declaration is focused protection for the world. That's absolutely essential. You can't just let the virus spread. You have to work very hard to identify people where they live. And I'll talk just a bit about what that means, because it turns out to be much more complicated than just the word social protection. But it's also much more complicated than just, well, the lockdowns potentially go. The second idea is for other populations, younger populations, not who are less risk from COVID. The lockdowns are even more. The lockdowns have asked young people to bear the cost of this disease that doesn't really harm them at high rates as much as the lockdowns. We induced guilt. We said, look, if you act like a normal young person, you're going to end up killing your mother or your father or your grandmother. And as Robert said at the beginning, in public health, we can actually try to get very far away from this kind of guilt and shame as it happens. It's not right to create guilt in people for spreading disease, especially a disease that spreads as easily as this one, with access innocent as time. So when we signed the Great Barrington Declaration, we wanted to write this as sharply as possible. The idea was very simple. Let young people live normal lives as best you can. You probably end up being careful of people who don't want to spread disease. Right? But don't induce guilt. Allow young people to live normal. But that's it. That's the Great Barrington Declaration. Focus protection for the old, normal life in study place. There's a trick to this actually. There's a reason why I think this is such a powerful idea. It's not a new thing. It's the same way that we've handled epidemics for the past 100 years, including most recently 2009 H1N1 epidemic. Every single epidemic for the last 100 years, we follow this strategy. Identify the vulnerable, protect them as best we can, disrupt society as little as possible. A healthy society that is engaged in normal activity actually produces more health than a society focused on control of single disease. So, what are the consequences? The consequences are devastating. I've already described this in the lockdown. How well have we got control of COVID? 700,000 people died. 80% of them over the age of 60 in the United States and elsewhere. 40% of the deaths are people with nursing homes. The disease, despite the lockdown, has spread and worldwide has killed at least 5 million people. The countries that have imposed lockdowns have fared no better than countries that have not imposed lockdowns. Sweden, for instance, has one of the lowest rates of overall excess deaths of all of Europe. Florida, which followed a much more focused protection kind of strategy, opened up and essentially fully opened up in September 2020. We had school in person, 100%, all of last year, has an age-adjusted death rate that's the same as California, which kept schools closed for most of the year. The marginal benefit of lockdowns, if anything, are focused on a single class of people. There are 7 people, maybe 35% of the American population, who could afford to work from home without losing their jobs. For the rest of the population, it effectively said, we call it essential, said, you go out, you get exposed, you serve the rest of society, while 35% can live at home and stay safe. For the people who stayed at home and stayed safe, well, they actually did okay. They did much better. In fact, they lost nothing, very little economically. They were exposed to the virus at much lower rates. They had deaths at lower rates. California and Los Angeles County. The black population had COVID death rates twice the rate of white populations. And Hispanic populations had COVID death rates 3 times the white population. In Florida, the rate of COVID deaths are equal across the population, white, black, equal. The lockdowns, in effect, were racist laws designed to protect a certain class of people at the expense of them. In fact, this has been a hallmark of the epidemic. We created a class of others. The first group was essentials. Another group we call this group of the 7 people who be careful. Right? How careful are these folks? If we stigmatize the getting of the disease, if you got the disease, what's the first question people get asked? Well, who gave it to you? Are you masked or not masked? Masked means you're careful or good. Unmasked means you're not careful and bad. Are you vaccinated or unvaccinated? created a class of people that, because they're invested, just by getting to their invested, we push them to the edge of society. Very soon, are you boosted or not boosted? That's it. We, in public health, created a new underclass. And we've done it with a very specific goal in mind, to address this disease. It's part of the policy, not simply a side effect of the policy. We shamed people to act a certain way. If you didn't act that way, well, then you were on the outside. You were at home. Okay, so that's the big declaration. That's my assessment of COVID policy through, let's say, December 21. December 21, an incredible event, which is unique in human history. In 9 months, we created a vaccine that actually is effective against brand new infection. Tested it and started deploying it at scale. A momentous event that has transformed the epidemic. And I should say, I think the vaccine is when we look back 50 years from now, we'll look at that as a huge achievement. Now, put yourself back in the center. You really face the path of how you can use this amazing vaccine, which cuts the risk of death by 98%. Right? So, 22% for me for mortality. I get the vaccine now, it's my death rate from getting infected is like 0.2%, 0.02%. So, go from 99.8% survival to 99.9%. Right? It's a big deal. And for older people, it's even bigger. 90% reduction in death rate is an enormous improvement in their survival if they get the vaccine. Well, how can we use the vaccine? We had a choice. We could use the vaccine to serve as a focus protection. Use it, prioritize older people for it, make sure every single old person on the face of the earth gets the vaccine first. Because that's who faces the risk. Or we could use it to try to eliminate it. We chose the second half of the first. We decided that if we vaccinated enough people, the disease would stop spreading, and we never would have to worry about it. Now, this sounds like a really worthwhile to do, right? Who here wants COVID to continue to circulate? I don't think there's a single person on the face of the earth who wants that. And so it seemed like we were going to try to eradicate the disease. But just like any policy, any worthy goal, we have to ask what it costs. Now, so what the cost had been, it was first we just some kind of technical. In order to eradicate disease, we only eradicate a single human disease, smallpox. First, and this is crucial, the disease has no reservoirs outside of the species that it infects. Right? So smallpox only infects humans. This disease infects dogs, it infects cats, it infects bats. There's a study done by the USDA that found that 40% of white-tailed deer in the US have COVID in them. 40% of white-tailed deer. This is not a disease that doesn't have non-human reservoirs. It has a lot of them. The second thing is you have to have the vaccine that's sterilized. That means that when you get the vaccine, it really does stop you from getting infected and transmitting disease. The smallpox vaccine is subject to an enormous amount of research, spanning centuries, and it was a fantastic vaccine to stop the infection. You got it, and when you get infected, you want to spread it. This vaccine, it turns out, we didn't know that in December 21, but it turns out that it does not stop infection. In fact, you can get the vaccine and still get infected. You can get the vaccine and still pass the disease on. I personally was vaccinated in April, and I got COVID in August. I got 3 days of fever, it was miserable. You should feel sorry. But I wasn't hospitalized, and I wasn't getting down. The disease, by getting the vaccine, was defanged. I didn't have a severe outcome, in part because of the vaccine. The vaccine is a fantastic tool for protecting yourself against severe outcome disease. If you, but let's take those two things in combination. It doesn't, they're non-human reservoirs, you don't have a sterilizing vaccine, and here's the third thing. This was the key to eradicating smallpox. We need international cooperation. Every country on earth needs to work together to eradicate it. And we don't have that kind of cooperation in the United States. It's terrible. Right? So what you have is a situation where zero COVID is not actually feasible. And yet we followed that policy with the vaccines. We vaccinated people. That was very good. By March of 2020, something like 70% of older people in the United States had at least first or second dose of the exact number. By now, almost 90% have had both doses of the vaccine. There's some places where it's last. The point is that we've done a very good job at vaccinating. We're still like 10 or 15% of the older population still is unvaccinated. That ought to be part of this. The world, though, well, most of the world actually doesn't have the doses of the vaccine. They're not going to get the vaccine. There are many, many older people around the world who still don't have that first dose, just because the vaccine is not. We created a many people to get the vaccine. Essentially, asking them to choose between, for some people who don't have the vaccine, for reasons, we can get into whether they're legitimate or not. Let's just take it as given. Well, some people switch to opinion because they don't trust public health. Well, for them, they're forced to choose between their livelihoods and getting the vaccine. Many of them are choosing to essentially let go of their jobs. Many of them are nurses that got COVID, recovered, and are immune, are much better, are effectively immune. The vaccine provides some protection, but very marginal protection. And they're heroes of COVID because they worked through the pandemic, and now they're out of us. Firefighters, policemen, electrical line workers, working class people around the country are facing this choice. And many choose not to essentially let go of decades-long careers rather than the vaccine. Africa, there's a very high person inside of Africa. So they're very famous in this basketball player who became the foregone millions of dollars in order to obtain the right kind of vaccine. We've turned the vaccine, which should have been a cause for celebration and a cause for freedom from this pandemic. We turned it into a tool of population, and we created a new outcast, undermining trust in public health, exploding vaccine hesitancy for other non-COVID vaccines. So, where we stand today, it's late October 2021. We have the tools at our disposal and the pandemic tomorrow. What are the keys to that? First, address the fear and panic of the population that we created as tools to create compliance with public health measures. And then second, vaccinate all the rest of the population. And not necessarily people. So put those two things together, we have all the tools we need to do that. The tools we don't have, that nobody has, we likely, unlikely we ever will have in real time, is the tools to eradicate disease. It will always be with us. The first time you get it, it's much better if you're vaccinated because it's likely that it will reduce the severity. The second time you get it, it will be much likely to be less harmful than the first time. So I expect the second time you get it will be mild. And the third time you get it will be another month. This is going to be circulated forever in this society. And while that sounds scary, there are 4 other coronaviruses that circulate in these societies. They're common cold viruses. You don't restructure our society around them. You should not restructure our society. And so those are the 2 choices. We either decide that we are going to return to public health that respects the kind of society we have, that respects human interactions, or we decide that we're going to restructure our society and not control a single virus forever. Thank you for this.